My name is Bill Osich, and I'm in the School of Earth Sciences. The Emeritus Academy is nothing short of an amazing community of Ohio State scholars, and I'm honored to be the chair of the steering committee for this academic year. Other members of the steering committee are TK Daniels, who is the chair-elect, and he's from Educational Studies. R.D. Nelson. R.D. Nelson, who was the past chair, and I especially want to thank Ardeen for her excellent work during the past year as she navigated our first COVID-19 year. Other members of the steering committee are Valerie Lee from English, Carl Lair from Internal Medicine, B.B. Miller from Dance, and Julia Watson from Comparative Studies. As I'm sure most of you know, the Emeritus Academy's home is within the Office of Academic Affairs. And at this time, I would like to introduce Helen Malone, to say a few words to us. Helen's home department is Educational Studies, and she is currently the Vice Provost for Academic Policy and Faculty Resources. Helen, you have the floor.
Thanks so much. Good afternoon, everybody. On behalf of the Office of Academic Affairs, I welcome you to another year. Unfortunately, what appears to be a second COVID year, but maybe we'll get back to be in person at some point in the not too distant future. It's one of my great joys to get to watch this group do the work that you do. Not all of the work I do in academic affairs is always positive, and so I really do enjoy coming and visiting the Emeritus Academy and seeing the work that you're doing, and also seeing the opportunities you're taking to take advantage of the small grants program, to come to these lectures and engage with one another. So it's thrilling that we have this group, that you all do such tremendous work, and that I get to see what that work is. So I'm so glad to see you all here today, and I look forward to engaging with you over the coming year. So I hope you enjoy today's lecture. And again, on behalf of the Office of Academic Affairs, welcome.
Okay, thank you, Helen. Before our talk today, I want to have a very short business meeting. Because you are all on this Zoom meeting, you know that all of the Emeritus Academy activities will be conducted via Zoom during the autumn semester. And a final decision on whether we go Zoom or in person for the spring has yet to be determined. It'll depend on, what's happening in the state of Ohio and what kind of regulations the Ohio states have, is all dependent upon the COVID crisis. The Emeritus Academy now has an up-to-date website for the autumn semester, but I want to note the following important deadlines that you may want to keep in mind. September 30th is the deadline for contributions to the Emeritus Academy September newsletter, and September 30th is also the deadline for new member applications. And then November 1st is the deadline for small grant applications. The newsletter items should be sent to R.D. Nelson. And please encourage anyone you know who is retired, who you think would be, and who is an emeritus, who would enjoy being a member, and encourage other people to join, because we'll welcome them with open arms. Also, if everything goes according to plan, soon I will send you just a little PDF, a short PDF that will outline some of the important dates for the entire autumn semester. Our meeting next month, will be Wednesday, October 6th, and our speaker will be Carter Finley from the Department of History, and his presentation will be Enlightening Europe on Islam and Ottomans. Also note that at the meeting next week, next month, I don't know why I'm saying next week, next month, that we are very pleased that the Ohio State University President, Christina Johnson, will join us and talk to us about the Emeritus Academy. So that'll be fun to have her join us. Again, too bad it can't be in person, but that's just not it. for this year. During our talk today, please mute yourself. And then after the talk, I will attempt to monitor questions which can be asked either in person or on the chat feature of Zoom. So now for the main event, it is my distinct pleasure to introduce Dr. Elizabeth Lenz, who is an Academy Professor of Nursing. Betty has had an amazing career in research and academic leadership. After receiving her PhD from the University of Delaware, Betty has been a professor and administrator at several universities, including being a professor and associate dean of Graduate Studies and Research at the University of Maryland, Baltimore School of Nursing, being a professor and director for the Center of Nursing Research at Penn State University School of Nursing, and being a professor and associate dean for research and doctoral studies at Columbia University School of Nursing. Betty came to Ohio State in 2001 as a professor and dean of the College of Nursing, and then she retired in 2013. Betty's published numerous books, book chapters, papers, and research journals, has had spectacular funding, and she's also received numerous awards, including the 1984 Distinguished Alumnus Award from DePauw University. She was elected to the American Academy of Nursing in 1988, and she has received the American Journal of Nursing Book Award, Book of the Year Award, twice for different editions of her book with co-authors that are titled Measurement in Nursing and Health Research. It's currently in its 5th edition. So it is my distinct pleasure to introduce Betty Lenz, whose talk today will be an approach to understanding the symptom experience. Betty, you have the floor.
Thank you. I'm very happy to be here with you, unfortunately not in person. But we will try to make our way through this. I'll be sharing with you some information about a theory that I was involved in developing, which has to do with symptoms. Next slide. Symptoms, we've all had them, going to have more of them probably in the future, but we've defined them as indicators of change in health status or functioning that are perceived by the individual. And usually, but not always, they're unpleasant symptoms. Next. This just shows you some of the differences between symptoms, which is our focus, or signs, which are objective and observable by other people. Symptoms are only perceived by the individual. I'm showing some examples here: pain, fatigue, nausea, shortness of breath, dizziness, heart palpitations, brain fog, and so forth. But having the symptom, being aware of the symptom as an outsider, a caregiver, for example, has to be communicated by the individual who's experiencing it, or we have to make inference from that individual's behavior. Obviously, with babies and toddlers and people who are unconscious and unable to speak, it has to be by inference. Next slide. Okay, why is it important that we understand symptoms? Well, they are key signs of changes in health and functioning, and they can have really important consequences for individuals, families, workplaces, and communities. People differ in the way they describe and express their symptoms. And it's interesting to try to figure out why that happens. Also, we know that individuals can learn effectively to self-monitor and manage their symptoms. So it's good that caregivers understand or try to understand what's going on, and so they can help them do that. Next slide, please. The theory of unpleasant symptoms, which is the theory I'm going to be talking about today, abbreviated as TOUS here, and no, not French, but just TOUS. It was developed by a team of 4 doctorally prepared nurses at the University of Maryland with expertise in medical surgical, obstetrical and home health nursing, and a philosopher of science, Fred Suppy, who helped guide us through the whole theory development process. The theory was developed inductively from practice and research, and the aim that we sought was to provide a framework that would help understand symptoms by researchers, clinicians, and patients. We wanted it to include more than just one disease or one symptom, and we wanted it to be patient-focused as opposed to illness-focused, and to really focus on patients' perceptions of their symptoms, what may have contributed to those symptoms, and how the symptoms impact their lives and the lives of those around them. Next, please. There are three major components to the theory. The one I'm going to start with is symptoms, because that really is at the heart of the matter. Next, please. We identified 4 different dimensions that we think are pretty important in order to try to understand what's going on with symptoms. The first one is intensity, which is the dimension that's most commonly measured. If any of you have been in the hospital, you've probably been asked to rate your symptom on a scale, a numerical scale from 1 to 10 or whatever. The second dimension is timing, and that speaks to things like the onset of the symptom, whether it was abrupt or gradual, and whether there were any specific circumstances that gave rise to it. Also, how long it lasts, whether it's acute or chronic, because those kinds of symptoms, acute versus chronic, are indicative of can be indicative of very different kinds of problems, and they can usually be treated very differently. And also whether the symptom recurs, how often, and with what kind of pattern. The third dimension is distress. That is to say, the amount of worry and unhappiness that the symptom causes the individual. It's affected by the amount of interference that the symptom causes with the individual's life. And we are pretty sure that it's also very much affected by the meaning of the symptom to the individual. If, take an example, a bout of nausea can be interpreted and mean something very different from chemotherapy, of somebody undergoing chemotherapy, and say a woman who's trying to become pregnant. The final dimension is quality, which simply refers to how it feels. In the case of pain, we know that there are several descriptors that people use to talk about their pain: stabbing, burning, pounding, and so forth. And also, if it's locatable somewhere, where is the symptom located? Next, please. The purpose of this slide is simply to tell you that we considered, and it's been supported, that these dimensions are in fact related to one another. Next slide. Okay, there's another related concept that's very much come into the fore of the literature in, I would say, the last probably 15 or 20 years, and that's the notion of symptom clusters, defined as 2 or more symptoms that occur simultaneously. The symptoms that are within the clusters are related to one another, but they can vary independently. Also, some clusters change over time, and others persist for years in chronic illnesses. Next slide. This is just to show you an example of symptom clusters that were found in a study of heart failure patients. They identified 3 different clusters with the number of symptoms ranging from 2 to 5, which is fairly common, I think. I would say between 3 and 5 symptoms are the most frequently found number. Next. To give you some examples, in cancer, there have been a lot of studies of symptom clusters, and pain, depression rather, and fatigue are very commonly identified as a cluster in advanced cancer. 3 to 16 persistent clusters have been found in various studies across multiple kinds of cancer. And as far as symptoms, individual symptoms, it's very common for them to, for the investigators to find 10 to 15 of them, again, across a variety of different types of cancer. Next. Okay, the next component is influencing factors. Those are next. Those are the conditions, events, experiences, and behaviors that affect symptoms. And we have identified 3 different categories of influencing factors: physiological, psychological, and situational or environmental. Next. Physiological factors are the ones you would probably think of first, because they include any current or pre-existing illnesses, medications and treatments. As any of us who watch TV know, medications often have a whole array of symptoms associated with them. Also, the age of the person, the gender, and some of their lifestyle behaviors also can impact their symptoms. Next, please. Psychological factors include moods like depression, anxiety, fear, anger. Also cognition, which includes what people know about symptoms and illnesses, their ability to understand information and explanations, and also the amount of uncertainty that may be involved in the symptoms, knowing, kind of wondering what's going to happen in the future. How do I know I'm going to be able to deal with this? And finally, the anticipated support that the individual thinks he or she is going to receive from others. Next, please. The situational factors we've divided into external and physical, and they're all external, but physical and social. The physical environmental factors include things that you would expect in the environment: temperature, humidity, noise, light, pollution. In terms of the place where the person lives, the condition of the place, the safety, and where it's located. For example, residents in inner city New York would probably result in more symptoms related to breathing issues than would be the case if someone lived in a rural area. Also, the healthcare facility, if someone's in a hospital or a nursing home, how clean it is, what conditions it's in, and also how adequately staffed it is and what kind of resources it has. Next. The external social environment includes the social network of the individual, which is to say, the family, neighbors, colleagues, and caregivers with whom they have interactions. And the important thing here is whether those interactions are helpful or stressful to the individual. Also, since we've developed this theory, certainly social media has become a much more important factor in the environment that impinge on the information in the social media certainly impinges on the individual's understanding of what's going on. Social support refers to the tangible resources that are available to the individual for help and care. And here we're not referring to what the individual thinks might be available, but what are actually available and provided and used. And social support can very much mitigate the impact of other factors or symptoms on the individual, on symptoms. The culture of the person, which in this case refers to the complexity of beliefs and expectations about health and illness, whether it's appropriate to seek help, and what is considered acceptable as opposed to pathological behavior. Next. Just a word in general about the influencing factors. Usually multiple factors are involved in affecting a given symptom or cluster of symptoms. And the factors in the three different categories are often related. And as I mentioned about social support, they can amplify or mitigate the effect of other factors. Most important here, it seems to me, based on the literature, are the psychological factors, particularly of depression and anxiety, and also the situational factor of social support. The influencing or the symptoms can also feed back to alter influencing factors. An example clearly here would be that as an individual's pain gets worse, this will tend to increase their level of anxiety. Next. The third component is performance, which is to say the effects or the outcomes of symptoms. Next. And here we've identified three different categories of performance. Physical performance includes the ability to move around, not only to walk and climb stairs, but also to move one's arms and hands and to have some balance. Also, stamina to sustain a particular activity and also to carry out the physical aspects of role performance, which includes activities of daily living and the ability to care for oneself. Cognitive performance refers to the clarity with which the individual is able to think and communicate, their ability to understand and remember and follow instructions, and also their ability to problem solve in daily life and in their employment. Social performance refers to their interaction with others and their ability to perform social roles, including those related to the family and employment. Next. Other investigators have identified a couple of outcomes and which were not actually included per se in the theory. One of those is the individual's ability to adapt to symptoms and illnesses. And then, quite importantly, quality of life or health-related quality of life. Now, this is a very complex concept. We opted not to include it, at least initially per se, because it is an amalgam of physical, cognitive, and social functioning. And it also, of course, reflects the individual's evaluation of his or her situation and the satisfaction with life. Next. Several performance outcomes can result from a symptom. In this example, dyspnea, shortness of breath, might mean that the individual cannot walk quickly. So he stays in his office, he gains weight perhaps, interacts less with his colleagues, and ultimately ends up shrinking his social network. Next. This is the same complex of outcomes, but demonstrating that the outcomes can feed back on the individual symptom and can also give rise to additional symptoms. In that previous example, it could mean that the individual, because of the social network being shrunken, less interaction, and being depressed and gaining weight, ends up being depressed. Next. Another example is that in a study of people with early Huntington's disease, this investigator found that neuropsychiatric symptoms, primarily depression, made the individuals less able to concentrate and communicate with others, which in turn made them withdraw socially, and ultimately that impaired their job performance. Next. The sequence of performance outcomes can have very serious consequences. In this example, which was a study of individuals who had had transplants or organ transplant surgery, the medication that they had received post-surgery had some pretty serious side effects, very uncomfortable ones, which made them inclined not to follow the directions of their caregivers. As a result, they developed new and worsening symptoms, and ultimately that led to organ rejection. Next. This is just the diagram that has been published to demonstrate what the theory looks like. Pretty, huh? It is complicated, as you can see. Next. Okay, the theory has been applied in quite a number of research projects. It has guided studies of many different symptoms, and I've just listed a few here: fatigue, pain, nausea, dyspnea, depressive symptoms, sleep disturbances. I would say that pain and fatigue are certainly the most commonly studied. Yes, next. It's been applied in research with a variety of different clinical populations. The most frequently studied are patients with cancer and also heart disease, but there are a whole lot of other illnesses where the symptoms have been examined. Either primarily, I would say, chronic illnesses or post-surgical situations. Also, women who are pregnant, in labor, or postpartum, and also people who have experienced domestic violence. There have not been very many applications in children. I would say probably something in the neighborhood of a dozen at this point. Not enough as far as we're concerned. As far as the non-clinical populations, the partners and caregivers of patients have been the primary subjects of studies. And the theory has been applied in, at least that I could find, at least 20 countries, which were identified through their publications. Yes, next. Okay, that was the research application. Now there have been some clinical applications. And for those of you who know much about clinical nursing, a lot of clinicians do a lot of fabulous work, but they don't publish it. But there are some pretty good examples here of applications of the theory in healthcare. Here are a couple that were where it was applied in heart failure. The first was a training program where patients were taught to monitor their symptoms and how to respond to changes. And the result was improvement in their self-care, their symptom management, and their self-confidence. Another study, which we'll call CASA, Collaborative Care to Alleviate Symptoms and Adjust to Illness, was carried out by a multidisciplinary team, including several physicians, nurses, and social workers. And the teams met weekly over a couple of years. And the care was delivered by several members of the team. Nurses developed ways to focus on symptoms and teach the patients about what to expect from their symptoms and how to deal with them. Primarily, they were focused on fatigue, breathlessness, and pain. The psychological aspects of care were handled by the social workers, and they focused on depression and adjustment to illness. They hypothesized that there would be a difference, this is an experiment, there would be a difference between those who were in the special care program and those who received usual care. Differences in functional status and in health-related quality of life. The results actually were that the experimental subjects had less fatigue and less depression, but there was no significant difference in functioning and health-related quality of life. Next slide. This diagram shows the conceptual model for the CASA study. There are, I don't know if you can see it that well, but there are several elements that are familiar if you know the theory of unpleasant symptoms. So they relied on our theory quite heavily in designing their study. Next. There have been, as I said, a lot of clinical applications in cancer care. And here are just a couple of examples. There was an experimental walking program where breast cancer patients who were post-surgery were encouraged to walk for a period each day. And as a result, this went on for, I think it was about 12 weeks. And as a result, the experimental subjects had lower severity of their symptoms and also better mood. Another one was a psychoeducational intervention for advanced lung cancer patients who were undergoing radiotherapy. They received education before the therapy started, and then about 3 weeks into it, about what to anticipate with their symptoms, how to care for themselves, what the symptoms might mean, and also explored the patient's goals. The result was that there was a positive effect on a symptom cluster, which included breathlessness, fatigue, and anxiety, and also positive effect on their functional ability. The third example that I included, just because it's so unique, is a clown-based program for kids undergoing therapy. Clowns provided several sessions of entertainment for these children when they were undergoing their chemotherapy sessions. And as a result, they had reduced fatigue and stress. Next slide. Another example, and this is an old one, but I'm including it because it was carried out by two of my co-authors on the theory. And that was an application in postpartum care. A low-income sample of inner-city Baltimore women postpartum were treated to try to prolong their breastfeeding by decreasing their fatigue. The investigators had identified fatigue as a key factor that encouraged women to stop breastfeeding. The way they addressed it was they addressed it all three categories of influencing symptoms, influencing factors, I'm sorry. Physiological, pain and fatigue were attacked, if you will, by teaching about diet and sleep and better positioning while feeding the baby. Psychological factors, primarily low esteem, self-esteem, they received counseling to build that esteem, and then social support and help was encouraged. The women were encouraged to use the help that was available to them. And the results were that the experimental subjects had lower fatigue and a longer duration of breastfeeding. But that was kind of short-lived, actually, as it turns out. The differences were in the first 6 weeks, but thereafter they became more similar to the control group. Next. Okay, so that's the theory. Where are we now as far as the implications of what we know so far for its use and its continued development? Well, I think we're pretty safe in saying that the majority of the hypothesized concepts and relationships have been supported in research. There's been some difficulty and some overlap between psychological influencing factors and symptoms, primarily depression. And that, as I see it, that's a lot a measurement issue, because the legacy measures of depression include many of the symptoms that that we would identify as problematic. We know that performance, that component of the theory, does need to be better described. The sequences, like the ones I talked about, were not really addressed at all in the individual cases of the theory. In subsequent publications that we've written about the theory, we have kind of elaborated on that, but I think we need to do just a better job of putting more of that in the literature. Also, it's become apparent to us that we should, in fact, add quality of life to be one of the outcomes. We do know now that clinical application is feasible, but it's complex and it's kind of expensive because it does involve a lot of time spent with the patient and family. We do know that the theory encourages comprehensive care that goes beyond simply the physical domain, and also means that the care that's given has to consider many different symptoms, possible influences on them, and multiple management strategies. And we do know, as I said earlier, that we do need to do more work to help the theory be more applicable in pediatric practice. And I think the main thing we need to do there is to focus more on the role of the family and the consequences of the symptoms for the family. Next. Okay, so what does this mean for you and me as patients? I think that it's safe to say that the theory does encourage us to have some expectations of our caregivers. First of all, we should expect that we will receive a comprehensive assessment of multiple symptoms, not only the ones that we actually mention, but other ones that are explored, and the dimensions of those symptoms at baseline, that is to say, the first encounters with the healthcare provider, and that assessment should be recurring and followed up in over the long term. We should expect a comprehensive treatment plan that includes the patient, the family, and any professional caregivers. Also, the treatment plan should instruct the patient and family about how best to monitor and manage symptoms, and of course, what to do if they perceive changes. Next. Okay, in conclusion, I believe it's safe to say that the theory of unpleasant symptoms is a useful conceptualization for guiding clinical research and practice. And it provides a helpful framework to build symptom science, not alone, but in conjunction with symptom-specific theories. And it provides a comprehensive roadmap for giving and expecting high-quality, personalized healthcare. Next. Okay, thank you. I appreciate your attention. I'd be happy to hear any questions, and to mention to you that the references that I had on the slides, I have put into a bibliography, which I'd be happy to email to you upon request. Thanks for your attention.
Okay, are there any questions for Betty?
I stunned him into silence.
Joe, do you want me to read your question?
Please.
Did you say yes?
I said yes.
Oh,
Yes.
yes. Okay, so Joe Donnemeyer, do you want to say it or do you want me to say it? You're there, you can say it.
Okay. What I wrote in the chat is a timely topic given the seemingly contradictory, inconsistent patterns of COVID and the reluctance to get vaccinated and ingesting deworming medicine for horses. Would this theory help us understand these nonsensical patterns in decision-making by some people?
Well, I think it could help a bit. I can't claim to be able to explain that because I don't understand it either. But I do think that some of those cultural and psychological factors are very important things that obviously people think about when they decide what they can do to prevent symptoms or what they should do if they initially perceive them.
Are you aware of any studies at the current time that look at the intersection of symptoms with particular cultural practices or beliefs?
I'm not, no. There may be some that I'm not aware of. It's a good question.
Great job.
Thank you.
Okay, Paul, you just asked a question. Should I read it or do you want to mention it?
Hi, Paul.
Why don't you go ahead and read it?
Okay, Paul Beck says, great job, Betty. Thanks. You've said that TOUS requires more comprehensive treatment. What are the barriers to delivering it? Among them, are insurers resistant to covering the extra costs? How about hospital administrators? And I think you can put et cetera after that.
Well, obviously cost, I think, is a factor. Time is another factor, especially in the institutional settings these days. You know, they're just being whacked by patients, not only with COVID, but other things as well. And this kind of an appropriate assessment does take time, and it takes time to develop a plan of treatment. And ideally, it's developed in conjunction with the family. And now the family can't even be in the room just by, you know, over TV. So I think there are some important ways that it could be helpful to inform what's going on, but clearly it's an expensive undertaking for sure. Did I answer your question?
Good, thank you. Yes. Mark DeBaud, do you want to ask your question? Oh, you're muted.
Muted.
Okay, we can't hear you, Mark, so I'll go ahead and read it.
Okay.
Are there any software programs that accept symptom input and provide a list of differential diagnoses with likelihoods? If so, do they suggest a list of objective signs and diagnostic tests to expand or limit the diagnoses?
Oh, I'm sure there are. I'm not a nurse practitioner. Okay. And of course, physicians have access to a lot of those programs. I'm off the top of my head, I can't tell you what they are, but I do know they exist. And they're used a lot in educating nurse practitioners and physicians for sure. And I'm sorry, I don't know the names of any.
Okay, so Betty, I was going to ask you a question. You know, since there seems to be sort of linear relationships between symptoms and the other levels of that you talked about in this, can you go through that and find places where you think a person is being hypochondriac, or actually discover new diseases? I mean, is there enough predictability in all of that to help you go outside the box rather than just stay within a known box?
Interesting question. Well, I think it's a question of the theory doesn't put any limits on what's a symptom in terms of what's perceived to be a symptom and what can be done about it. So I'm not sure I'm not answering your question. Could you ask me again?
Well, again, there are predictable patterns that you.
Right, right.
When the patterns are unpredictable, so can you begin to diagnose things that actually aren't a disease, and or to discover new diseases?
Theoretically, you could.
Yeah. Okay.
Yeah. I don't think we want to restrict all the thinking to those, certainly to those boxes. But if you think about the consequences of what people are thinking are symptoms, it's kind of wide open. And similarly, what people perceive to be symptoms, there aren't any limits on that either, in terms of what they describe. So I don't think there are any real limits to it, to tell you the truth.
Yeah.
I mean, it's worth exploring. If somebody mentions something that, doesn't sound familiar or makes no sense, I would say what should happen is you should really explore in depth what they're talking about, what they're experiencing, what they think it means, if anything. And then to try to figure out how that relates to what might be going on pathologically, if anything.
Okay. Julia, you have a question here. Do you want to read it or ask it, or should I read it?
I'll read it because there's a typo in it. The history of medical treatment long treated symptoms differently depending on the gender of the patient. We know about the diagnosis of hysterical women in earlier centuries, and there continue to be differences in how symptoms are heard and evaluated by race and ethnicity. And I think not only in the US, especially for women of color. How might the model address continuing inequities in responding to symptoms?
Good question. I think maybe we just need to be more explicit. I mean, I had included in that list that racial or cultural, as well as racial and age differences can impact the symptoms. What we did not really address was how they might impact whether symptoms are even recognized or how they're perceived by caregivers or even by their families.
Yes.
We know that there are a lot of differences in the way families respond to the symptoms that individuals complain about. And those are very important determinants. Yes, you're right. Thank you. Probably needs to be emphasized more.
Well, and perhaps, more diversity of practitioners doing the listening would also contribute.
Indeed, indeed. We hope that having females involved, as many nurses are, not all certainly, may help with a little bit of that. But clearly there is not as much racial and cultural diversity in nursing and probably in medicine as we would like to see. So it does make a difference in terms of what people are asked and what the caregiver manages to hear when people express what they're experiencing.
Thank you.
Okay, are there any other questions for Betty?
As I said, if anybody wants those references, just email me at lenz.23.
Okay. Well, hearing no more questions, then I would like to thank Betty very much for a very interesting talk. And, actually, I think maybe gives all of us ideas of how integrated various aspects of medical treatment are. And it is a very complex thing at some level. And the more people that are involved, the better the outcomes might be.
Yes. And I think just encouraging your caregivers to just go a little bit beyond throwing you a medication to try to deal with what you seem to be experiencing. Because often that does not take care of the problem.
Interesting. Yeah, fascinating. Okay, well, again, unless there are any other questions, then I'd like to again thank Betty very much. And
My pleasure.
we will see you all in approximately a month for our next talk.